let's talk some more. For our next speaker, we have Dr. Adam Feldman, practicing urologist at Mass General Hospital, also someone who teaches urological surgery at Harvard Medical School, and as one of his best achievements ever, he is a co-founder of Sentient. Please, Adam, take it away.
Great, thank you. Well, thank you, Andreas, and everybody at Osmocosm for having me speak. It's an honor. And what I want to talk about is sort of the importance of all the things that we're discussing here in olfaction, of how to detect disease and how to identify disease and why that's important from a clinical perspective. So just to quickly touch on cancer incidence in the United States, these are the top malignancies in the estimated new cases in 2022. Prostate cancer, the leading cause of cancer in men, in addition lung, colon, and rectum, bladder, and then in women, breast, lung, colon, uterine cancers. And so in addition, you can see, as we know, cancer is a leading cause of death in the United States, and prostate cancer, which is one that we're specifically interested in urology, is the second most leading cause of cancer death in men, and lung, colon, and pancreas as well, and then also in women, lung cancer and breast cancer. And so if you look, interestingly, when we look over time, this is a graph from cancer statistics from 2022 that looks at the rate of cancer incidence and the rate of cancer mortality. And what we can actually see is we see that there's been some decline in overall cancer mortality, and whether that relates to early detection, we hope, and I'll give some examples, and whether that or relates to improved treatment, we hope, in many cancers. But you can see that there's a decline, or has been a decline, in mortality over the past really 2 decades. And the other thing that we know, if you look, these are not all the sort of charts of malignancies, but what we can see here is this is cancer stage, okay? So localized cancer, so localized, regional, distant, and what you can see is that early stage, and I think this is intuitive, but early stage and identifying malignancies at an early stage and treating them at an early stage, and this is a stage of presentation that you have improves 5-year survival. So this is prostate cancer as an example, and I'll also look at lung cancer as an example. So this is the incidence of cancer over time. So this is the rate per 100,000 population. This is year, going from 1975 to around 2019. And the line here, this sort of, I don't know what I'll call it, maroon line, I guess you'd call it, is prostate cancer. And what you can see is this spike here in incidence. And this spike here in incidence represents in around 1992 when we started using PSA to screen for prostate cancer. And what happened? You say, well, what happened here? Why did the incidence all of a sudden sharply go down? Because we identified many cases that were out in the population, and then the incidence leveled off after we had found them. But what you note here, and I'll get back to that in the next slide, is you see the incidence go down starting in the sort of around 2010 and the subsequent 5 years or so, around a little bit before 2010. And what that relates to is the decrease in screening of cancer, okay? So I'm gonna get back to that point in another slide. This same line, colored line, is prostate cancer mortality. And what we see is that from around 92, the time we started screening with PSA, that mortality for prostate cancer had actually declined. And you can see here it starts to level off a little bit, okay, in terms of the decline. And then if you look at the red line, that's actually lung cancer. Lung cancer also around the same time improved screening with CT scan or CAT scan for high-risk individuals, reduction in smoking also, and improved treatment strategies. The mortality for lung cancer has gone down. So let's get back to prostate cancer for a second. What I was alluding to with reduction in screening was because the U.S. Preventive Services Task Force, which assesses screening tests for various malignancies and other things as well, made the decision to say that we should not be using blood-based PSA screening for prostate cancer. And so what resulted, and this was as a result of 2 randomized trials, which I think there were variations in interpretation of the data from those trials, but that was their decision, and the primary care community followed suit. And so what happened after that? And this was actually in 2011. What happened after that? What happened was that in the urologic community, we started to see men present with prostate cancer at later stages. So we see that localized disease had gone down at presentation, but regionally advanced and distant metastatic disease had gone up. And that results in a reduction in, or I should say, more difficult treatment for patients and potentially a worsened mortality for patients. So we know that early detection, what I think I'm trying to demonstrate, early detection is important, okay? Many groups are searching for clinically relevant, we'll say, biomarkers, and if you do, and in fact, so many people agree that if you do a search for, PubMed search for biomarkers in prostate cancer, you get over 43, almost 44,000 hits. Biomarkers in bladder cancer, which I recently gave a talk at a urologic oncology course in bladder cancer, and you get nearly 11,000 hits. But identifying a new reliable biomarker, quote unquote, is not easy. And we also have to consider the cost of screening, and that's really what led to the U.S. Preventive Services Task Force. Cost of screening, cost of all the diagnostic tests that go along with potentially positive tests. So this morning I actually ran a journal club for our residents, our trainees, and we talked about sort of diagnostic tests and went through sensitivity, specificity. Okay, so anyway, the way we identify or way we assess a diagnostic test is the sensitivity. So the actual number of true positives, meaning that if they, the ones who are test positive and are really positive, but over the number of true positives plus false negatives. Okay, so how good is the test at identifying disease? The specificity. Okay, so that actually specificity of a test gets to the false positive of a test. And then we also think about the positive predictive value. If the test is positive, is it really positive? With a negative predictive value, and if it tests negative, is it really negative? And that's really important when we're thinking about, great example, which I'm going to touch on, is a urinalysis. You go to your doctor, you have a urinalysis, you have microscopic blood in the urine. And how do you evaluate that? That translates to a huge expense and a huge burden for, hang on. I think the other one complete. So that translates to a big burden for our healthcare system. Thanks. So one of the things that we want to do, so patients who have I'll just keep this moving around a little bit. Patients who have what's called microscopic hematuria or microscopic blood in the urine, their risk of having cancer is about maybe 2 to 4%, right? So evaluating all of those patients becomes a big expenditure. So we want to try to find, this is actually a paper I was discussing this morning with our trainees about a novel test to try to triage patients who should have a full evaluation with a cystoscopy, which is an invasive procedure, imaging, who should be evaluated if they have microscopic blood in the urine. And so I won't go into the details of that test, but the other way that we evaluate tests is what's called an ROC curve, which I'm sure many of you know, developed with engineering, and an area under the curve. In other words, what's the true positive rate? What's the false positive rate, and how well does that test work? But we also have to think about the disease prevalence. So for example, in those patients who have microscopic hematuria, what is the prevalence of disease, and how is that going to affect their test performance in terms of the negative predictive value? So as the prevalence of disease goes up, the negative predictive value will go down. So if you have a low prevalence of disease, you're going to automatically have a very high negative predictive value. And then as the prevalence of disease goes up, the positive predictive value goes up, no matter what the characteristics are of the test. And the important thing that I had to remind our trainees is that actually prevalence disease doesn't affect the sensitivity and the specificity of the test or the area under the curve. So that can be a very helpful thing to look at, and to go look across populations and rely on some generalizability of your test. So what do we measure? Where do we measure it? Do we measure, for classic biomarkers that we think about? Something, I've been sort of doing research in a long time. Do we look in urine? We can look in blood. We can look in tissue. There are different types of biomarkers. There's sort of cytopathologic biomarkers using for bladder cancer, for example, looking at the cells, spinning down the urine, looking at the cells, trying to identify malignant cells, or trying to identify genetic changes within those cells. Proteomic markers, including urinary proteins to diagnose both prostate cancer, bladder cancer, genomic markers as well. Someone had touched on cell-free DNA. That is a huge area of research. That also microRNA, and then metabolomics, so the omics. And I have to admit, I really like the term volatilome. So we can use also, I think this is relatively newer, the microbiome and the volatilome, if I'm pronouncing that exactly correctly, but this is, just to demonstrate that there are other ways that, the newer ways. This is the paper that Andreas was the senior author on, and looking to identify, new methods for detecting cancer. So we know that outcomes are better when detected when cancer outcomes are better when detected at earlier stages. In prostate cancer, we already have demonstrated that when you detect them at later stages, so we demonstrated once that when you screen early, you can change mortality. And if you stop screening early and detecting them early, you can actually negatively affect your patient populations. I think Andreas had touched on a point of, the classic biomarker. So when we think about classic biomarkers, so for example, when I was in my fellowship now, 15 years ago, and I was working in a mass spec lab and looking for novel biomarkers in prostate cancer, I was looking for 1 or 2 or 3 potential proteins that we could use to detect prostate cancer. The problem is that prostate cancer and most malignancies are extremely heterogeneous. So to think that 1 or 2 or a combination of even 5 biomarkers are really, even in a multivariable model, are going to be sufficient, I think is that's not going to work. So rather signatures that are dynamic and that we can use to detect not just one subtype of prostate cancer or bladder cancer, but multiple subtypes, I think are what we're going to need. So. And there are, we hope there are more accurate, non-invasive, and affordable diagnostic strategies that are critically important in prostate cancer and other malignancies. And affordable is key because healthcare expenditures are a major problem for us all. Great, thank you.
Thank you so very much. That was very instructive and educational. Okay, Dimitri will have a question. I have a question, and if we have one from the audience also. My question is simple, and I have many because it's such wonderful talk. You made a point that early detection leads to less mortality. Is that for all cancers? If the cancer, I hear bad things about, let's say, pancreatic cancer.
Yeah.
And I wonder, if there's nothing you could do for me if I have this disease, and I know about it 10 years earlier, is that better for me than if I know it 1 year before I die? I don't know what the stress will do.
So it's really hard. The hard thing, so you asked the question, is it true for all cancers? In conversations, I see a lot of patients. A great example is pancreatic cancer is hard because there's no way to screen for it, right? And you sometimes find it on imaging. That's actually a good example. So not uncommonly, a patient gets a CAT scan for, totally other reason, and we see, a small pancreatic cyst, recommend evaluation in the pancreatic cyst clinic. Okay, that may never amount to anything. I also routinely have conversations. One of the things I also take care of in addition to prostate cancer is kidney cancer. So we have a whole sort of, body of research looking at small kidney cancers, and do we really need to treat them? Similar to like prostate cancer, do we need to treat them? So the trick is not finding all cancers, it's finding the clinically significant cancers. So there are many types of cancer that may never affect anybody in their lifetime. And so we have to balance that. And that is, that plays into the whole cost of care and healthcare system for health.
Yeah, thank you, doctor.
Yeah.
I'm a lawyer. I don't handle medical malpractice cases, but I have a friend of mine who does. So we were talking about Sentient and the startup.
Yeah.
And what he had said to me is that about 65% of the cases, the medical malpractice cases, involve prostate cancer. So yes, the cost obviously of the examinations, the cost to society is significant if we don't have a good way to kind of figure things out. But the cost to society later, when there's a failure to diagnose, is also a significant factor, which makes this type of technology even more important.
Yeah. Yeah, I'll comment. I mean, I occasionally will review some med mal cases. And so, there are cases that, for example, my primary care physician didn't, send a PSA or tell me that I could get a PSA blood test. And this gets to the poor performance characteristics of that test and gets back to, that test not being recommended. And so, is that negligence? Is it, is that sort of malpractice, or was that primary care physician following guidelines at the U.S. Preventive Services Task Force? It's very confusing for, I'm a primary care physician. I'm monitoring their blood pressure. I'm, trying to prevent heart attacks, and yet I'm trying to screen them for cancer and trying to figure out if I should or should not be screening them for certain cancers. So it's really confusing for people. But yeah, it's the source of a lot of difficulty.
Yeah, and I think the interesting part was that this law firm was actually interested in developing the technology, even though it was against their financial interest. But
yeah,
thank you.
Okay, do we have anything from the web? Nope, we're good. We're cool. Thank you so much, Adam. Learned a lot.